Hello and welcome to the next Saviours Essential Question Series, NEET PG 2025, Part 8 of the medicine, where we are going to have a discussion on the approach to the questions that are asked in relation to the neuromuscular disorder as promised. So without wasting any time further, let's see the first part of the question which has been kept. Means we have divided the question into three parts based on the information provided. So let's see what is the information provided in the first part. A 35-year-old male presents to the emergency with the progressive weakness in both legs over the past 5 days. You see, every time you get a question on neuromuscular disorder, the first thing always provided is the patient demographics and the history. Now, what is the patient demographic? The first one is age. You see, if the age is young, that means in the childhood or teenage, then what you have to think of is a Duchenne muscle dystrophy or the Becker muscle dystrophy or the spinal muscular atrophy. But in case of the age which is provided in the middle age group, then you have to think of myasthenia gravis, the Lambert-Eaton syndrome, and the multiple sclerosis. For elderly, it has to be amyotrophic lateral sclerosis or the paraneoplastic syndromes. Although there could be an overlap, like for myasthenia gravis also or Lambert-Eaton syndrome also, the age in the form of elderly could also be provided. As far as gender is concerned, then X-linked predominantly in males is provided in case of muscle dystrophies like Duchenne or Becker's. Next, the second thing is the onset and progression of the weakness. Now, you see, acute or subacute, that means days to weeks. It is a feature of Guillain-Barré syndrome, the myasthenia gravis, or the botulism. But in case if it is chronic, that means months to years. If it takes months to years for this weakness to progress, then it could be amyotrophic lateral sclerosis, the muscular dystrophies, or hereditary neuropathies like Charcot-Marie tooth disease. Now, if you go back to the question, then what they have provided to you, the weakness began in feet and gradually ascended to involve the thigh over the last 24 hours. That means it can be considered within the category of being acute or subacute. Now, yesterday also we have talked about the relapsing or remitting kind of the weakness, which is a feature suggestive of multiple sclerosis. Now, the third point, which would always be provided to you in the history, is the preceding history, a preceding event, if at all it is significant. Like, for example, if there is a recent GI infection or any viral illness which can trigger Guillain-Barré syndrome. Now, recent respiratory tract infection because of mycoplasma pneumonia, it might trigger Guillain-Barré syndrome. Exposure to the canned food or the IV drug abuse might result in botulism, as we already know. Some of the malignancies like lung cancer might result in the Lambert-Eaton syndrome. The breast or the thymoma in particular results in myasthenia gravis. Now, autoimmune conditions, if at all are provided like SLE, Hashimoto thyroiditis, then again, it might trigger myasthenia gravis, polymyositis, or dermatomyositis. This is the importance of preceding history in the question. Now, if you go back to the question, now, after having the weakness, he reports a recent upper respiratory tract infection 2 weeks ago, which resolved on its own. He denies any history of trauma, new medications, or similar episodes in the past. So, based on this history provided in the first line of the question, you might get some idea that where exactly the question is going or what the examiner is trying to ask. Now, the second important part which is provided to you in the question are the neurological examination findings. Like here, the motor findings, symmetrical weakness in both lower limbs, proximal and distal. Now, from here, proximal and distal means both the thigh and the leg muscles. All right. Weakness also noted in the upper limb. As far as deep tendon reflexes are concerned, they are absent in both the upper lower limbs. Sensory involvement is absolutely normal, but mild paresthesia in feet is observed. Cranial nerve involvement, mild bilateral facial weakness, unable to close the eyes fully, but there is a postural dizziness because of orthostatic hypotension. So these are the neuromuscular examination findings which are provided. And it is exceedingly important or extremely important for you to know about the pattern of the weakness which is observed in these neuromuscular disorder. Now, as far as the proximal muscle weakness, that means shoulders or the thigh first, is a feature of myopathies like polymyositis or muscular dystrophies. But the distal muscle weakness, that means feet or the hands first, is a feature of peripheral neuropathy like Charcot-Marie tooth disease or diabetes. Now, fluctuating weakness, that means where there is a worsening with the use, is essentially a feature of myasthenia gravis that you already are aware of. But the weakness that improves with the activity is a specific finding of Lambert-Eaton myasthenic syndrome that we have already talked about. Now, asymmetric weakness is a feature of amyotrophic lateral sclerosis or mononeuropathy. Sudden onset descending weakness is a feature of botulism, and most importantly, the ascending kind of the paralysis is a specific finding for Guillain-Barré syndrome. So this is the pattern which will always be provided to you in a question for you to further consolidate the kind of the answer that you are getting through. Next thing which is provided are the reflexes. You see, if there is a hyperreflexia, that means the features of upper motor neuron type of the palsy, it is a feature of ALS and multiple sclerosis. But if there is hyporeflexia or areflexia, which is a feature of lower motor neuron palsy, is a feature of Guillain-Barré, the Lambert-Eaton or peripheral neuropathies. The normal reflexes are observed in case of myasthenia gravis and the other myopathies. So particularly the reflex related questions or reflex related findings are provided in case of multiple sclerosis where there is hyperreflexia. Now, sensory involvement, absent where there is pure motor disorder, majority of the time myasthenia gravis because there is no sensory involvement at all. As far as GBS is concerned, it is also predominantly a motor disorder, but some sensory findings can also be observed in case of Guillain-Barré syndrome. So don't just rule it out on the basis that there could be a sensory finding which is present or involved. And finally, the cranial nerve involvement. You are well aware of the fact that ptosis and diplopia are the features of myasthenia gravis. Ptosis plus fixed pupil is the feature of botulism because pupillary findings are typically absent in case of myasthenia gravis. Now, if there is a facial weakness, which is bilateral, it is a feature of Guillain-Barré syndrome. And if there is dysarthria, dysphagia plus tongue atrophy, it is a feature of amyotrophic lateral sclerosis. Now, if you go back to the question, and see what all are the features provided to you. There is a symmetrical weakness. There is absent deep tendon reflexes. There is no loss of sensation. There is mild bilateral facial weakness, and there is orthostatic hypotension, plus the preceding finding which is provided. So you have already reached the diagnosis that probably the question is based on the Guillain-Barré syndrome. But further, in order to consolidate this question further, there will be a question part 2, which also will be provided to you by the examiner, where there are investigations given. Like complete blood count CBC is normal, electrolytes are normal. The lumbar puncture finding, because it is a weakness which is observed, the lumbar puncture finding is elevated proteins and the normal WBC count. Normal WBC count, that means if there is a ruling out of the infection. Now, nerve conduction studies, as far as nerve conduction studies are concerned, there will be a slowed conduction velocity and conduction block in peripheral nerves, and anti-ganglioside antibodies is found to be positive. And once you see this line in the question, in this long question, then you have already confirmed the diagnosis that the answer for this question is nothing but the Guillain-Barré syndrome. So what is the importance of the diagnostic test for other neuromuscular disorders, which is likely to be kept? Like adrophonium test, yesterday we have talked about, it is a feature of myasthenia gravis where there is an improvement. And if there is worsening, it is because of the cholinergic crisis. Now, repetitive nerve stimulation test we have talked about, like decremental response is observed in myasthenia gravis, but incremental response is observed in Lambert-Eaton syndrome. The single fiber EMG finding, where there is increased jitter seen in case of myasthenia gravis. Electromyography, degenerative potential is seen in amyotrophic lateral sclerosis as well as degenerative peripheral neuropathies. The creatinine kinase are found to be elevated. No need to say, you already know about this, the muscular dystrophies or myositis. And as far as CSF analysis is concerned, there will be elevated protein and normal WBC count in case of Guillain-Barré syndrome, while MRI or a spinal cord, means MRI of the brain, where there are multiple white matter plaques are seen. It is a feature which is suggestive of multiple sclerosis. And whenever you get the question on multiple sclerosis, you are likely to get this as a finding in the question. So this is the importance of the diagnostic test on the basis of which you can reach the answer. So obviously, you can very clearly identify that what is the most likely diagnosis for this particular question, and the answer for this question is Guillain-Barré syndrome. Now, there are some associated findings which are related to these neuromuscular disorders like thymoma. is a feature which can be seen in or which might lead to myasthenia gravis. Small cell lung cancer is found to be associated in 40 to 60% of the cases with Lambert-Eaton syndrome. Heliotrope rash or Gotton's papules in case of dermatomyositis, while pes cavus foot drop in case of Charcot-Marie-Tooth disease. So this is something which might be provided to you as a hint in the question so that the answering the question becomes easier. Once you have reached the diagnosis, here they are also asking about the management. So as far as the first line of the management of these conditions are concerned, like in case of myasthenia gravis, the first line of management we are discussing over here, acetylcholinesterase inhibitors like pyridoxine is the first line of management. And in this immunosuppressive therapy like corticosteroids or azathioprine or mycophenolate mofetil, even rituximab or cyclosporine, they are required where there is a moderate to severe myasthenia gravis or if the pyridoxine is inadequate. All right, in order to have a long-term control, the immunosuppressive therapy is required. But for the management of the myasthenia crisis, the plasmapheresis is required. What is myasthenic crisis? It is a life-threatening exacerbation of the weakness which might result in respiratory failure. All right. Next is the management of the Lambert-Eaton myasthenic syndrome. You see, the first thing, treat the underlying cause because there is a strong association with the small cell lung cancer, like in 50 to 60% of the cases, as I told you. So first identify it. So screen for the malignancy is crucial, and then you have to treat it. Along with this, there is a symptomatic management by enhancing the acetylcholine release. And for that, the first line of drug is 3,4-diaminopyridine, which is responsible for prolonging the calcium channel opening, increasing the acetylcholine release. Recently there is a FDA approved drug which is alternative to 3,4-aminopyridine is amifamidine. Now let's talk about the treatment of the Guillain-Barré syndrome. Now, the treatment of Guillain-Barré syndrome, it focuses on immunotherapy, supportive care, and preventing the complications because it is an acute immune-mediated demyelinating polyneuropathy. So early intervention is crucial to reduce the morbidity and mortality. Now, the first line of the management is plasma exchange of plasmapheresis or intravenous immunoglobulins. Now, both are effective but should be started within 2 weeks of the symptoms. But the problem is that there are specific indications, like if there is a respiratory involvement where there is a forced vital capacity of less than 20 ml per kg, or there is rapid progression of the weakness, or if the patient is non-ambulatory. All right. As far as supportive care is concerned, respiratory support, the pain management, the DVT prophylaxis, the physical therapy rehabilitation, and the autonomic dysfunction management is considered for the management of the Guillain-Barré syndrome. As far as botulism, antitoxin is required for the management of the botulism. You see, in the management of the amyotrophic lateral sclerosis, first of all, there is no cure. The treatment is only supportive. A glutamate inhibitor, that is riluzole, it slows disease progression by 3 to 6 months. And Adravone is an antioxidant therapy which might slow the functional decline. As far as non-invasive ventilation or BiPAP is concerned, it might prolong survival in case of respiratory failure. And palliative care, gastrostomy feeding for dysphagia can also be considered. For the management of polymyositis or dermatomyositis, you already know the corticosteroids or the methotrexates are required. So hope you have understood that how would you be able to mark the answer related to any question which is asked in context to this neuromuscular disorder. Hope you find the session helpful. Please join our Telegram group and never miss any update related to the upcoming NEET PG 2025 examination. Thank you very much.